Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Okay guys, let's continue our review of the 2024 ICD-10-CM official coding guidelines. If you have not yet had a chance to go in and review these guidelines, go back to last Thursday's video. I uploaded a video on the part 1A of the official coding guidelines. All right, let me minimize my box and let's get started. Again, we are at B. We've already done A, and now we're officially at B. I'm having a time with this box. Okay. Let me first show you the official coding guidelines. B is general coding guidelines. Number 1, locating a code in the ICD-10-CM. Says to select a code in the classification that corresponds to a diagnosis or reason for visit documented in a medical record. First, locate the term in the alphabetic index and then verify the code in the tabular list. Read and be guided by instructional notations that appear in both the alphabetic index and the tabular list. It is essential to use both the alphabetic index and tabular list when locating and assigning a code. The alphabetic index does not always provide the full code. Let me say that again. The alphabetic index does not always provide the full code. Selection of a full code, including laterality and any applicable seventh character, can only be done in the tabular list. A dash at the end of an alphabetic index entry indicates that additional characters are required. Even if a dash is not included in the alphabetic index entry, it is necessary to refer to the tabular list to verify that no seventh character is required. So let me show you with my notes. There are 3 steps to coding. 1, locate the main term in the alphabetic index. 2, verify the code in the tabular list. And 3, assign the verified code. Assign the code that you confirmed in the tabular list before assigning. So how do you locate a main term in the alphabetic index? The main term describes the condition of the patient, not the body part. So for example, breast mass. The main term in breast mass is what? The main term is in bold print, starts with a capital letter, and is farthest to the left. So based on the condition breast mass, I would look up mass. So here it should say mass. Okay. Subterms are indented to the right under the main term. They're in regular type with a lowercase letter. So based on the condition breast mass, I would look for breast under the main term mass. So let me show that to you. Here's a replica of the alphabetic index. We're under the main term mass, and we're going to go down to breast. And there's your code. Okay. All right, referring back to those official coding guidelines. What's the level of detail in coding? Diagnoses codes are used and reported at their highest number of characters available and to the highest level of specificity documented in the medical record. ICD-10-CM diagnoses codes are composed of codes with 3, 4, 5, 6, or 7 characters. Remember, I-9, we went as far as 5, but with I-10, we've got 7 characters. Codes with 3 characters are included in the ICD-10-CM as the heading of a category, or codes that may be further subdivided by the use of 4th, 5th, 6th, each which provides greater detail or specificity. A 3-character code is to be used only if it is not further subdivided. A code is invalid if it has not been coded to the full number of characters required for that code, including the 7th character if applicable. And I tried to make this a little clearer here where I said, if I needed even more specificity, some subterms have additional subterms indented further to the right under the previous subterm. I call these sub-subterms. For example, with the main term mass, underneath there's a subterm abdominal, and then there's a sub-subterm epigastric. It's describing greater specificity of the mass that is in the abdominal area, but for specificity, it's telling you it's in the epigastric region. And we know that the epigastric area is right above your umbilical, your navel. So when I go to the previous here where it had mass and then subterm abdominal, notice its mass is bold print, flush left, starts with a capital letter, main term mass, subterm indented, starts with the lowercase, regular print, abdominal, subterm, but I'm identifying it as epigastric, where I'm giving you a subterm. It's further indented underneath the first subterm. There's the epigastric, R19.06. All right. The alphabetic index does not always provide the full code. So selection of the full code, including laterality and any applicable 7th character, can only be done in the tabular list. And there's usually a dash at the end of an alphabetic index entry that indicates that additional characters are required. But even if a dash is not included in your alphabetic entry, your alphabetic index entry, it's necessary to refer to the tabular list to verify that no 7th character is required. So let's refer to main term mass and subterm ear. So let me go to mass, subterm ear. See how that H93.8 has this box with the check in it? For this AAPC ICD-10-CM book, the H93.8 is a box with a check in it that lets me know additional characters are required. So when I look that code up, H93.8, it's right here, H93.8, notice it's saying check the 5th. Well, H938 is 4, so I need that 5th character. But when I get to that 5th character, H938X, it's saying I need 6 characters. So it's going to be H938X1 or 2. It's going to be all the way up to 6 characters no matter what. It's either 8-1, 8X2, 8X3, or 8X9. So H938 can expand all the way up to 6 digits. Therefore, this code must be a 6-digit code. I can't stop at 5 and I can't stop at 4. It's not a legitimate code unless I carry it out all the way to the number of characters for that particular category, and in this case, subcategory. Okay? Let's keep going. All right, number 2, let's refer back to the guidelines. Level of detail and coding. Diagnoses codes are to be used and reported. Okay, we just did this part here. We did 2. Let me make sure my notes cover that as well. 2. Level, refer to the guideline H93.8 above. We did that. All right, let's go back to the guidelines. We're at 3. I want you to see it in the guidelines, and then I add my little touches. Code or codes from A00.0 through T88.9 and Z00 through Z99.8, and our new codes U00 through U85. Says the appropriate code or codes from this category. These categories must be used to identify diagnoses, symptoms, conditions, problems, complaints, or other reasons for the encounter or visit. So my codes just say straight from the guidelines. I agree with exactly what it's saying here at 3. 4 says signs and symptoms. Codes that describe symptoms and signs, as opposed to diagnoses, are acceptable for reporting purposes when a related definitive diagnosis has not been established or confirmed by the provider. And Chapter 18 of ICD-10-CM Symptoms, signs, and abnormal clinical and laboratory findings not elsewhere classified contain many, but not all, codes for symptoms. Main thing I wanted to stress here with number 4 was, do you know the difference between a symptom and a sign? I always say symptoms are observed from the patient. Doc, I'm having these headaches. Doc, I'm lightheaded, I'm dizzy. These are my symptoms as the patient. So as I'm telling my doctor my symptoms, ding, 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 these are signs to the doctor or the physician of a disease process. So again, symptom, patient, sign, physician. Okay? All right, 5. Let's look at number 5. Conditions that are an integral part of a disease process. Signs and symptoms that are associated routinely with the disease process should not be assigned as additional codes unless otherwise instructed by the classification. So it's exactly what it's saying here. If these symptoms add up to this diagnosis, then don't code the symptom codes, just code the diagnoses code, because that's what these symptoms are. Oh, lightheaded, a little dizzy, not feeling well, head is hurting. Oh, you got hypertension. Oh, so I just code, if the doctor says these are symptoms of hypertension, patient does have hypertension, I just code hypertension. I don't code the signs and symptoms. I just code the definitive diagnoses. So again, conditions that are an integral part of the disease process are captured under that disease process. 6, I think we covered 6 as well. Conditions that are not an integral part of the disease process. Additional signs and symptoms that may not be associated routinely with the disease process should be coded when present. If it doesn't lead to a definitive diagnosis, then code the sign or symptom. 7, multiple coding for a single condition. In addition to the etiology, which means cause, or manifestation, which is a result of, either it's the cause of the disease or scarring that's a result of a burn. Conventions that require 2 codes to fully describe a single condition that affects multiple body systems. There are other single conditions that also require more than 1 code. Use additional code notes are usually found in your tabular list at codes that are not a part of an etiology or manifestation pair, where a secondary code is useful to fully describe a condition. The sequencing rule is the same as the etiology manifestation pair. Use additional code indicates that a secondary code should be added if known. And they gave you an example here. Bacterial infections that are not included in Chapter 1. It says a secondary code from category B95, which identifies Streptococcus, Staphylococcus, and Enterococcus as the cause of diseases classified elsewhere, or B96, other bacterial agents as the cause of diseases classified elsewhere, may be required to identify the bacterial organism causing the infection. So a use additional code note will normally be found at the infectious disease code, indicating a need for the organism code to be added as a secondary code. So let me show you that. And then also code first. Let me show you. Multiple coding for a single condition. All right, we referred to the guidelines, paragraphs 1 and 2. Did we cover 2 as well? With the code first. Okay, but let me show you this at N39.0. You're going to learn that N39.0 is urinary tract infection. So N39.0 right there. Urinary tract infection site not specified. But if you have a urinary tract infection, you know it's an infection. It's telling you here, use an additional code from B95 through B97 to identify the infectious agent. So if it's a urinary tract infection due to E. coli, then I would go under main term infection, find E. coli, and use that as an additional code, because it's telling me here in my tabular list that I need an additional code to identify the infectious disease. Just like my coding guidelines told me here, that I might need an additional code. If the code at the tabular doesn't include the infectious organism, use an additional code to identify the infectious agent. And then you'll see code first. They're also under certain codes that are not specifically manifestation codes, but may be due to an underlying cause. So when there's a code first note and an underlying condition is present, then the underlying condition should be sequenced first if known. In other words, if they didn't have this other underlying condition, then more than likely they wouldn't have whatever condition they have today. And then you have a code, if applicable, any causal condition first. There's a note that indicates that this code may be assigned as a principal diagnosis when the causal condition is not unknown or not applicable. So if a causal condition is known, then code that condition and sequence it as your principal or first listed diagnoses. And multiple codes may be needed for sequela, which is a result of, or a complication code, and obstetric codes to more fully describe a condition. So let's look back at what, make sure I'm covering everything I have on my guidelines for this. Only thing I have here is like code first, diabetic retinopathy. You know that retinopathy is a disease of the retina in the eye. But if it's a diabetic retinopathy, then it's saying that because of this patient's diabetes, today they have retinopathy. Now understand, you can have retinopathy without diabetes. But in the case of a diabetic retinopathy, then it's letting me know that due to the patient's diabetes, now they have retinopathy. So when I go to code it, retinopathy diabetic, it's going to tell me, see diabetes first, code first, diabetes. And then code, if applicable, any causal condition first. I use the example of insomnia due to a medical condition. If you're unable to sleep at night due to another condition, then that other condition should be identified first, because that's the reason that today you have insomnia. Okay? Hopefully this makes sense. And when I look up insomnia, I didn't identify the code here. Here it is, insomnia G47.0. It's telling me I need a 5th digit to code it. But notice at insomnia, due to a medical condition, it's telling me here, code also any associated medical conditions. So if they're coming in today for the insomnia, then that would be coded first. But if there's an underlying condition, follow the guidelines of your classification. ICD-10-CM will tell you how to appropriately code that. Here it says code also any associated medical condition. Okay. 8, acute and chronic conditions. So let's go to the guidelines on number 8. If the same condition is described as both subacute, acute or subacute, and chronic, and separate sub-entries exist in your alphabetic index at the same indentation level, code both and sequence the acute or subacute code first. So first thing I ask you here is, what is the difference between acute and chronic? We know that acute is immediate. It's happening now. It's urgent. Where chronic is ongoing. It's not immediate. It's usually long-term. So if you know the difference between the specificities with the two, acute and chronic, then you can understand putting acute conditions first. And then combination codes. Let me go to combination for 9. A combination code is a single code used to classify 2 diagnoses or a diagnosis with associated secondary process or manifestation, which we just identified, or a diagnosis with an associated complication. Combination codes are identified by referring to subterm entries in the alphabetic index and by reading the inclusion and exclusion notes in the tabular list. Remember, we talked about inclusion and exclusion in last week's video. Assign only the combination code when that code fully identifies the diagnostic conditions involved or when the alphabetic index so directs. Multiple coding should not be used when the classification provides a combination code that clearly identifies all of the elements documented in the diagnoses. And when the combination code lacks necessary specificity in describing the manifestations or complications, an additional code should be used as a secondary code. And so I identified in 9, an example was canaliculitis, acute and chronic. This condition can be both acute and chronic in the same patient. So if we looked up canaliculitis in your alphabetic index, right there, canaliculitis. Remember we talked about non-essential modifiers beside the main term? So right here, just at the main term, it identifies acute. And because chronic is indented underneath, if I code chronic, this stands for chronic, but it will also include acute at this one code, because this one code will include chronic by itself, or because acute is a non-essential modifier, which means it's still here, chronic is indented underneath canaliculitis, then this one code identifies both acute and chronic. And be careful, because notice at the chronic, there's some more digits needed to appropriately code this condition. All right, so watch your indentation levels, but it identifies both acute here. If I was just coding acute, I'd use this code with the additional characters. But because I'm identifying chronic and acute, because chronic is indented, this one code and the additional digits would include acute and chronic here. Okay. All right, let's keep going. Sequela. Sequela is under 10. A sequela is usually, it says here, is the residual effect. It's a condition produced after the acute phase of an illness or injury has terminated. There is no time, and this is one thing it didn't stay with me. There is no time limit. I can't say after 6 months. No, it could happen immediately. It could be years later, but there is no time limit on when a sequela code can be used. It says here the residual may be apparent early, such as in a cerebral infarction, or it may occur months or years later, such as that due to a previous injury. Examples of a sequela include scar formation resulting from a burn, a deviated septum due to a nasal fracture, infertility due to tubal occlusion from old tuberculosis. So coding of sequela generally requires 2 codes, sequenced in the following order. The condition or nature of the sequela is sequenced first, and then the sequela code is sequenced second. An exception to the above guidelines are those instances where the code for the sequela is followed by a manifestation code identified in your tabular list and title, or the sequela code has been expanded at the 4th, 5th, or 6th character level to include the manifestation. And the code for the acute phase of an illness or injury that led to the sequela is never used with the code for the late effect. And the only category that I know here, it says here, it's been done in complications of pregnancy, childbirth, and the puerperum. I've seen it in cerebral vascular disease. Most patients with the stroke, the late effects of the hemiparesis when they're paralyzed on one side, etc., that category has been expanded to include the late effect with the current condition the patient's experiencing. Let's make sure I covered everything. Sequela is a result of something. For example, a scar is a result of a burn. So when I go in, and the way you look them up is you go to main term sequela, okay? And see how cerebral vascular disease under sequela is right there. And notice the infarction is over here. And those are categories that I know have been expanded to include the condition today as a result of a previous stroke. All right, impending or threatened conditions. Number 11. Code any condition described at the time of discharge as impending or threatened. When the doctor says, you didn't quite miscarry yet, but you're threatening, a miscarriage, or you're impending a myocardial infarction, you're threatening to have a heart attack. If it did occur, then code as a confirmed diagnosis. Miscarriage, heart attack, code it as if it's confirmed. But if it did not occur, then reference the alphabetic index to determine if the condition has a subentry for impending or threatened, and also reference main term entries impending or threatened. If the subterms are listed, then assign the given code. If the subterms are not listed, code the existing underlying condition and not the condition described as impending or threatened. And that's pretty much what I'm saying here is if the condition says impending or threatened, go to main term impending or threatened. Did I make a copy of those? Yeah, see here, here's impending. Coronary syndrome, delirium tremens, myocardial infarction. So if you're threatening a myocardial infarction, there's a code. Here's threatened. Let me find it on here. Threatened. Here it is. Threatened abortion, abuse, job loss, anxiety concerned, labor, etc. All of these. Loss of job, miscarriage, unemployment. So go to those main terms. But if the condition was not listed here, then it's telling me go to that condition and code it as confirmed if I can't find it under impending or threatened. All right, we're at number 12, reporting the same diagnosis code more than once. Each unique, they said unique for a reason, ICD-10-CM diagnosis code may be reported only once for an encounter. I can remember in ICD-9, if it was bilateral, we assigned the code 2 times. We don't need that anymore with ICD-10 because now ICD-10 has been expanded to identify right, left, bilateral, unspecified, etc. So this applies to bilateral conditions when there are no distinct code identifying laterality or 2 different conditions classified to the same ICD-10-CM diagnosis code. It's there. Our coding now identifies the same diagnoses more than once. Okay, I think those guidelines are really clear. If there's any questions, let me know. And then even with laterality, let's look at 13. It says refer to the guidelines. It's self-explanatory. Some ICD-10-CM codes indicate laterality, which means right or left, specifying whether the condition occurs on the left, the right, or bilateral. If no bilateral code is provided and the condition is bilateral, then assign separate codes for both the left and right. And if the side is not identified in the medical record, then assign the code for the unspecified side. When a patient has a bilateral condition and each side is treated during separate encounters, then assign the bilateral code as the condition still exists on both sides, including for the encounter to treat the first side. So even if they're only treating one side, because the patient has that condition bilaterally, then it's appropriate to code it bilaterally. And then for the second encounter for the treatment after one side had previously been treated and the condition no longer exists on that side, then assign the appropriate unilateral, because remember they already corrected the other side by the time you're coming in for the second treatment, for the side where the condition still exists. And you see that quite a bit with cataract surgery that's performed on each eye. They tend to do one eye at a time. It says the bilateral code would not be assigned for the second encounter, as the patient no longer has the condition in the previously treated site. And if the treatment on the first side did not completely resolve the condition, then the bilateral code would still be appropriate. When laterality is not documented by the patient's provider, code assignment for the affected side may be based on the medical record documentation from other clinicians. If you find it documented in the chart that it was on the right and the physician didn't tell you, then long as the documentation identifies which side, then you're okay to code it. And if there is conflicting medical record documentation regarding the affected side, then the patient's provider should be queried for clarification. And in codes for unspecified side should rarely be used when the documentation in the record is sufficient to determine the affected side and it is not possible to obtain clarification. So again, as I always tell my coders, review the entire record anyway when coding, just for that clarity. 14, documentation by clinicians other than the patient's provider. Did I have anything more at 13? Nope. And 14, I just said refer to the guidelines. So let's read those guidelines at 14. Code assignment is based on the documentation by the patient's provider. This provider could be a physician or other qualified healthcare practitioner legally accountable for establishing the patient's diagnoses. There are a few exceptions when code assignment may be based on medical record documentation from clinicians who are not the patient's provider. In this context, clinicians other than the patient's provider refers to healthcare professionals permitted based on regulatory accreditation requirements or internal hospital policies to document in a patient's official medical record. And some of these exceptions include if the physician says the patient has obesity, morbid obesity, etc., we tend to look for body mass index, BMI. Even the depth of non-pressure chronic ulcers. If the physician just says patient has ulcers, chronic ulcers, nurses tend to document the level or the depth of the ulcer. So we can do that. Same here with pressure ulcer staging. Nurses tend to grab that more, document that more than physicians, and you're okay to grab it there. Coma scale, NIH stroke scale, social determinants of health, laterality, blood alcohol levels. We always check the lab on those so we can identify what it is, and under immunization status. With blood alcohol levels and body mass index, I always say when I'm teaching that a lot of times patients don't think they're obese when it comes to obesity, but that BMI helps you determine that. Same thing with your alcohol level. Patients will say, oh, I'm not intoxicated, but their blood alcohol level states that they're over a certain limit, therefore they are intoxicated. These are additional codes that we can add for the specificity that we need to justify the provider's documentation. And so it just says here the information is typically or may be documented by other clinicians involved in the care of the patient. Notice it's a dietitian. However, the associated diagnoses must be documented by the patient's provider. And if there's conflicting medical record documentation, either from the same clinician or different clinicians, then the patient's provider should be queried for clarification. Because I always tell my coders, we code physician documentation. Physician said it, we can code it. However, that nursing, the labs, the x-rays, the other ancillary services can give us greater specificity in our coding to more accurately code. So long as it corresponds with what the physician says, patient is obese, then we can go to that BMI to prove that the obesity is there. All right, so that's 13 and 14. Yep, refer to the guidelines. All right, now 15 talks about syndromes. Let's look at syndromes. It says follow the alphabetic index guidelines when coding syndromes. In the absence of the alphabetic index guidance, assign codes for the documented manifestations of syndromes. Additional codes for manifestations that are not an integral part of the disease process may also be assigned when the condition does not have a unique code. So the only thing I did here was copy the page in my alphabetic index for syndromes. And guys, look, this is pages, all three of these lines on that one page. And this is just one page from the 2024 ICD-10-CM alphabetic index to disease and injuries and syndrome. It took up, I think, about 3 of these full pages for just syndromes. So there are quite a few. All right, we're at 16. Documentation of complications of care. Now, code assignment is based on the provider's documentation of the relationship between the condition and the care or procedure unless otherwise instructed by the classification. The guideline extends to any complications of care, regardless of the chapter the code is located in. So realize it is important to note that not all conditions that occur during or following medical care or surgery are classified as complications. There must be a cause and effect relationship between the care provided and the condition, and the documentation must support that the condition is clinically significant. It is not necessary for the provider to explicitly document the term complication. For example, if the condition alters the course of the surgery as documented in the op report, then it would be appropriate to report a complication code. Query the provider for clarification if the documentation is not clear as to the relationship between the condition and the care or procedure. Biggest thing I want to say here is remember, a complication is usually something that went wrong as a result of. There needs to be, as they state here, a cause and effect relationship. Because of this occurring, this happened. That's where a complication comes in. Because this was treated, this happened. That's a complication. It alters the care. Make sure I have nothing else at 16. All right, now we're ready to go into 17. Borderline diagnoses. If the provider documents a borderline diagnosis at the time of discharge, then the diagnosis is coded as confirmed, unless the classification provides a specific entry. For example, borderline diabetes. I think we hear that quite a bit. If a borderline condition has a specific index entry in ICD-10-CM, it should be coded as such, borderline diabetes. Since borderline conditions are not uncertain diagnoses, no distinct measure, since borderline conditions are not uncertain diagnoses, no distinction is made between the care setting, inpatient versus outpatient. Whenever the documentation is unclear regarding a borderline condition, coders are encouraged to query for clarification. Make sure I don't have anything else put in here. Yep. And I showed you what it looks like under borderline. So if I go to the main term, borderline, right there. You have borderline diabetes mellitus, borderline hypertension, borderline osteopenia, borderline pelvis with obstruction during labor, or borderline personality. All of these are borderline conditions. But again, remember what your guideline says. If a borderline condition has a specific index entry, then it should be coded. But if it's not, then you code it as if confirmed. All right, use of sign and symptoms, use of sign, symptoms, and unspecified codes. Sign, symptom, and unspecified codes have acceptable, even necessary uses. It says, while specific diagnosis codes should be reported when they are supported by the available medical record documentation and clinical knowledge of the patient's health condition, there are instances when signs, symptoms, or unspecified codes are the best choice for accurately reflecting the healthcare encounter. Each healthcare encounter should be coded to the level of certainty known for that encounter. It says here, as stated in the introductory section of these official coding guidelines, a joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. The entire record should be reviewed to determine the specific reason for the encounter and the conditions treated. And I always tell my coders this: we code physician documentation, yes, but read the entire record. Know what's going on with your patients so that you can more accurately code it. And if a definitive diagnosis has not been established by the end of the encounter, it's appropriate to report codes for signs and or symptoms in lieu of a definitive diagnosis when sufficient clinical information isn't known or available about a particular health condition to assign a more specific code. It is acceptable to report the appropriate unspecified code. And they gave you an example of pneumonia. Didn't tell you what type, just said patient has pneumonia. The unspecified code should be reported when they are the codes that most accurately reflect what is known about the patient's condition at the time of that particular encounter. It would be inappropriate to select a specific code that is not supported by the medical record documentation or conduct medically unnecessary diagnostic testing in order to determine a more specific code. So again, we said earlier that symptoms are from the patient, and as the patient tells the physician their symptoms, ding, 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 they're signs to the physician of a disease process. But sometimes your symptoms don't lead to a definitive diagnosis. And if a definitive diagnosis cannot be determined, then all you can code are these signs or symptoms. And I see that quite a bit on an outpatient basis. With going to your physician's office with a headache, a lot of times they will treat headache. But you'll learn that a headache is an indication of something else going on in the body. It could just be stress, sleep, you need a lack of sleep, anxiety, etc. But because when you went to the physician's office and you're lucky to spend 10 to 15 minutes in the office with the physician, all they hear is headache, then they're just going to treat headache. If it's anything more, that headache will eventually lead to the definitive diagnoses. But if all your physician treats in that little 10 or 15 minutes in their office is the headache, then all we can code is headache. Okay, let's keep going with our guidelines. We are down to 18. Yes, we did 18, so let's see what else I have. Just refer to the guidelines. They are straight to the point. I agree. All right, 19, code for healthcare encounters in hurricane aftermath. We're almost finished, guys. All right, and these come straight from the guidelines. I agree with this use of external cause of morbidity codes. And I'm being told that external cause coding is state dependent. It depends on which state you're in, whether or not you capture these codes. But just know that an external cause of morbidity code should be assigned to identify the cause of injuries incurred as a result of the hurricane. The use of external cause of morbidity codes is supplemental to the application of ICD-10-CM codes. External cause of morbidity codes are never to be recorded as a principal diagnosis or first listed. Put all your diagnoses codes first, and then your last code should be identifying the external cause. And remember, there's a separate index for these. The appropriate injury code should be sequenced before any external cause codes. The external cause of morbidity codes capture how the injury or health condition happened, which is the cause, the intent, was it unintentional or accidental, or was it intentional, such as a suicide or an assault, the place where the event occurred, the activity of the patient at the time of the event, and the person's status. Were they civilian? Were they military? They should not be assigned for encounters to treat hurricane victims' medical conditions when no injury or adverse effect or poisoning is involved. External cause of morbidity codes should be assigned for each encounter for care and treatment of the injury. External cause of morbidity codes may be assigned in all healthcare settings. For the purpose of capturing complete and accurate ICD-10-CM data in the aftermath of the hurricane, a healthcare setting should be considered as any location where medical care is provided by licensed healthcare professionals. And how do we sequence these? Codes for cataclysmic events such as hurricane take priority over all other external cause codes except child and adult abuse and terrorism, and should be sequenced before other external cause of injury codes. So again, we'll do these external cause codes, especially the hurricane, first, unless it's child abuse or adult abuse or terrorism. It says assign as many external cause of morbidity codes as necessary to fully explain each cause. For example, if an injury occurs as a result of a building collapse during the hurricane, external cause codes for both the hurricane and the building collapse should be assigned, with the external causes code for the hurricane being sequenced as the first external cause code. And for injuries occurred as a direct result of the hurricane, assign the appropriate codes for the injuries, then followed by the X37.0 hurricane, and in any other applicable external cause of injury codes. Now that code X37.0 also should be assigned when an injury is incurred as a result of flooding caused by a levee breaking related to a hurricane, and X38 flood should be assigned when an injury is from flooding resulting directly from the storm. X36.0, and you notice those additional digits, collapse of a dam or man-made structure should not be assigned when the cause of the collapse is due to the hurricane. The use of X36.0 is limited to collapses of man-made structures due to Earth's surface movements, not due to storm surges directly from a hurricane. And then others include injuries that are not a direct result of the hurricane, such as an evacuee that has incurred an injury as a result of a motor vehicle accident. Then assign the appropriate external cause or morbidity code to describe the cause of the injury, but do not assign the X37.0 hurricane. If it is not clear whether the injury was a direct result of the hurricane, then assume the injury is due to the hurricane and assign X37.0 hurricane, as well as any other applicable external cause or morbidity codes. In addition to code X37.0 for hurricane, other possible applicable external cause or morbidity codes include X30, exposure to excessive natural heat, X31, exposure to excessive natural cold, and X38, flood. Make sure I don't have anything else like that on here. So I just have on here, for A, the use of external cause or morbidity codes, you want to code how, activity, place, and status. Those are the 4 external cause codes. And it's straightforward as far as the sequencing and other external cause or morbidity codes. And then the last part of this B says use of Z codes. Z codes, which other reasons for healthcare encounters, may be assigned as appropriate to further explain the reason for presenting for healthcare services, include transfers between healthcare facilities, or provide additional information relevant to a patient's encounter. ICD-10-CM official guidelines for coding and reporting identify which codes may be assigned as principal or first listed diagnoses only, secondary diagnoses only, or principal, first listed, or secondary, depending on the circumstances. So make sure with this, you check to make sure, is this Z code a Z code that can only be a first listed, or is this a Z code that cannot be a first listed? And it will tell you in your classification in ICD-10-CM, particularly in the tabular list, it will say this code can only be a primary or principal diagnoses code. So pay attention to those. Possible applicable Z codes include homelessness, inadequate housing, extreme poverty, persons awaiting admission to an adequate facility elsewhere, unavailability and inaccessibility of healthcare facilities, unavailability and inaccessibility of other helping agencies, encounter for health supervision and care of other healthy infants and child, encounter for respiratory or ventilator dependence during power failure. So can you see how these Z codes tend to be a little different? There are other reasons for healthcare encounters. They're not actual diagnoses, but they're other. But it justifies healthcare services. So we need to code them. All right, let's see. External cause and morbidity codes and the Z code listed above are not an all-inclusive list. Other codes may be applicable to the encounter based upon the documentation. Assign as many codes as necessary to fully explain each healthcare encounter. And since patient history information may be very limited, use any available documentation to assign the appropriate external cause of morbidity and Z codes. Other Z codes that I'm shocked that aren't listed on here are allergies to penicillin, sulfa, different things that physicians need to be aware of. All right, let me double check my guidelines when I pulled them over. Use of Z codes. That's it, guys. We have finished B. 1B of the 2024 ICD-10-CM official coding guidelines. My next video will be on C. We're getting into chapter specific coding guidelines. All right, guys, thanks for taking this journey with me. Hopefully I'm bringing better understanding of these official coding guidelines to you. Any questions, feel free to email me at codemastercoach@gmail.com. And next Thursday, I will be back and we'll pick up C. Thanks, guys. I'll see you in the next one.